the question will be hopefully after the meeting. Then now I have the pleasure to present to you Professor Loibl, Germany, who will give us today a very interesting talk about platinum combination and targeting angiogenesis in the neoadjuvant setting. What is the evidence?
Thank you very much. So I think the scenes have been set, and there will be some slides which you have already been seen from Gunther, but I think this is just okay, thank you very much. So this is the first slide, and I just wanted to start with showing you what we achieved with the different trials. And you have heard about the GEPAR-6 result, that the carboplatin increased, and also the CRGB trial increased again the PCR rates by not only adding carboplatin but also by using the bevacizumab, and this is my talk. What is the role of bevacizumab? What is the role of carboplatin in triple-negative breast cancer in the neoadjuvant setting? So there are a couple of trials in the neoadjuvant setting looking at the role of bevacizumab, and I'll start with the GEPAR-Quinto trial, where we looked at EC docetaxel plus minus bevacizumab, and the patients who did not respond to the first 4 cycles of EC plus minus bevacizumab, they were actually not continuing with docetaxel but received another treatment. So what you can see here is that bevacizumab is increasing the pathological complete response rate, and when we look into the subgroup of the triple-negative breast cancer, then we had a more than 10% increase by adding bevacizumab to EC and docetaxel. But the overall survival was kind of disappointment, and not what we have seen with the platinum agent. The disease-free and the overall survival were completely overlapping in the group of bevacizumab or not. And even if we looked into the subgroup of the triple-negative breast cancer patients, there is no difference with or without bevacizumab. The American, the NSABP, the B40 study also looked at the effect of adding bevacizumab, and they, in parallel, they looked at the effect of adding or using gemcitabine, but I'm only focusing on with or without bevacizumab. But they used it in a different way. They did not stop the treatment at the time of surgery, but they continued for another 6 months with bevacizumab. And here you can see again there is an increase in the pathological complete response rate in the group using bevacizumab, not only if you look at the PCR in the breast, but also you look in the PCR breast and nodes as the definition of pathological complete response. In contrast to the GEPAR-Quinto study, they saw the main difference in the hormone receptor positive cohort, and not in the triple-negative cohort. So a benefit in the hormone receptor positive cohort in B40 and in triple-negative cohort in GEPAR-Quinto. And another difference is if they added bevacizumab and continued it beyond surgery, they saw a small, a marginal increase of the disease-free survival in the group who received bevacizumab. This is the dashed line here, and they also saw a significant increase in the overall survival by using bevacizumab as part of the neoadjuvant and as part of the adjuvant therapy. And again, the difference and the effect mainly, as in the for PCR, in the hormone receptor positive cohort, as you see here in the red circle. So this is kind of conflicting, and when they looked at the hormone receptor positive and negative cohort separately, you can see, and what I have said you in my last presentation, in the hormone receptor negative cohort, and these are the triple negatives in this setting, the PCR is the main driver and is the main prognostic factor. So the PCR group with or without bevacizumab is here, and the non-PCR group is here. Whereas in the hormone receptor positive cohort, the picture is not that clear. We have the no PCR and no Bev group is the lowest line as shown here, and the middle line is the no PCR plus Bev group. So and the other two groups are above. So if you have received bevacizumab and you have achieved a PCR, then you did quite well, as with a PCR and without bevacizumab as well. We looked, and this was presented just a couple of weeks ago in San Antonio by Peter Fasching. He looked at the BRCA mutation and looked if there is a difference in this triple negative, in this cohort here. And you see here that as in the JEPR-6 study as presented just a couple of minutes ago by Gunther, the patients with a BRCA mutation achieve a higher pathological complete response than the patients with a wild type tumor, triple negative tumor. The difference is quite large. It's an absolute difference of 20%. And when we looked at the simple, that BRCA as a prognostic factor shown in the panel next to it, here we have the mutation carriers, here we have the wild type patient, and you see there is a significant difference between the patients who have a mutation carrier compared to the wild type patients. So BRCA is actually a good prognostic factor. If it would be a good prognostic factor without therapy, we don't know that. The patients respond better to the treatment, and therefore they might do better in the end, but certainly BRCA is not a negative prognostic factor. The patients are doing better. Now it gets a little more complicated. We look at the effect of pathological complete response and prognosis stratified for the BRCA mutation status, and here it's a little bit different compared to the JEPR-6, but again we see the two PCR curves on top, although they separate a little bit, and the mutation carriers a little bit lower than the non-mutation carrier, but there is no significant difference between the two groups. And the same is for the no PCR patient. They are doing worse, and the lowest group is the no PCR and the non-mutation carriers, and the mutation carriers with no PCR in green. So green is hope they do a little better as shown here. So the story is not that simple, but remember the patients not responding to the first 4 cycles of EC and bevacizumab, they have not been integrated here, and we don't know the result if we would have not selected these patients in the JEPR-6. So all patients, irrespective of their early response, were actually taken into account for PCR as well as for the follow-up. There is a third trial which I just want to address briefly, and it's the Atria trial, and they looked also at adding bevacizumab, but they used a different chemotherapy regimen. They started with the taxane with docetaxel, and then applied FEC, and same in the group with bevacizumab. But the results are similar. Adding bevacizumab improved the pathological complete response, small by absolute 5%, but is a statistical significant difference, irrespective of the definition of PCR. But as in the JEPR-Quinto study, I'm mixing up the numbers as I go along, the ER-negative patients again derive the largest benefit from adding bevacizumab and not the hormone receptor positive patients. So we have 2 trials supporting Bev in the triple negative setting, and 1 trial supporting Bev in the hormone receptor positive setting, but these are subgroup analysis, and we have always to be careful with that. So this you have already seen. I'm now moving to carboplatin, but both carboplatin trials also included bevacizumab, and therefore the trial results are not that clean and not so easy to interpret if the patients would not have received any bevacizumab. The JEPR6 as the GLGB study, both in a randomized fashion in the CLGB study with and without bevacizumab, and the JEPR6 for all patients with triple-negative breast cancer, they received bevacizumab. And both trials really achieved more or less the same results. Survival was positive in JEPR6 as seen, and this was only for the triple-negative cohort. And again, the PCR rate is higher in the germline mutation carriers compared to the wild-type cohort, and the absolute difference for carboplatin is larger in the wild-type cohort, but in both groups we have an effect for adding carboplatin. And the disease-free survival by BRCA and PCR, again, the PCR group here and the non-PCR group here, this is the same picture for all triple-negative studies. And here again, irrespective of the BRCA status, the patients do better if they achieve a PCR, and those without a PCR do worse. The ZLGB also looked at the survival, and you have seen this from Gunther. The difference is smaller, but I wouldn't say there is no effect, but it's simply not statistically significant, and we have to differentiate between statistically significant and clinically meaningful. 5% or 5% difference in the disease-free survival at 3 years is still a difference. And we have to maybe wait for the results for overall survival to make the story complete. So in summary, the bevacizumab in the neoadjuvant therapy increases the pathological complete response, but data on survival are conflicting, as the data are conflicting for the subgroup, which is the main benefitor for the bevacizumab. We would say, or we would more believe the data and the triple-negative breast cancer, because this supports the hypothesis everybody had before. And also the Beatrice trial, although not statistically significant, the curve with bevacizumab was above the survival curves for the group who did not receive bevacizumab. I think we can clearly say that carboplatin added in the neoadjuvant setting, irrespective of the chemotherapy background, increases the pathological complete response. It also improves the DFS. We don't know the exact absolute difference, because one trial showed a large difference, another trial showed a smaller difference, which was therefore not statistically significant. I would say we think we should mature the data a little bit and await for the overall survival data and have a further detailed look into the subgroups. The BRCA carriers, and I think all trials, showed that very consistently derive a higher benefit from neoadjuvant therapy because they are simply more chemosensitive, and this is independent of the given therapy, and because they are so highly sensitive to chemotherapy, adding something to already a very good chemotherapy makes only a small difference. And overall, the BRCA carriers, and these are also has also been shown before, they have a very good prognosis overall, and I think if we treat them with the best chemotherapy we have, the patients don't need, and if they achieve a PCR, these patients don't need to worry. And it seems that the platinum works independent and irrespective of the BRCA status, and I think at least in the neoadjuvant setting, and at least if you give the patients a combination therapy, because in the metastatic setting, if you remember the TNT trial, they received one agent, platinum or a taxane, and there they saw the platinum effect only in the BRCA mutation carriers. But if you give a combination therapy with an anthracycline or with an anthracycline alkylating agent like cyclophosphamide, the added value of carboplatin is not so important. And there, I think this is the main difference, and that's why we see not such a big difference in favor of adding carboplatin in the patient with a BRCA mutation. And I think this summarizes the data we have currently and supports the use of carboplatin in the triple negative cohort to some extent, but I think overall bevacizumab, although increasing the PCR, is not a standard of care in triple negative breast cancer. Thank you very much.
Thank you, Professor.